Welcome everybody. Today's webinar is organized by CIRSA European Trainee Forum. My name is Małgorzata Milnerowicz and I'm a 5th year resident of radiology, enrolling the interventional radiology training in both peripheral and neurovascular interventions in Wrocław Medical University in Poland. Topic of today's webinar is interventional neuroradiology. And our webinar will consist of 3 parts. First, it will be carotid stenting, then brain aneurysm and AVM embolization, and thrombectomy in ischemic stroke. Each of the topics will be discussed by the amazing interventional radiologists from all over Europe. They will present you the etiology of the diseases, pros and cons for endovascular treatment over the surgical one, and they will discuss step by step how the procedure looks like.
During our procedure, it's always good to use a roadmap for the catheterization of the external carotid artery and for the catheterization also of the internal carotid artery and to bypass the lesion. In order to cross our lesion, we have to use a 0.14 guide wire. So once we have placed our sheath here, we proceed with angiography. We have a better look of our stenotic lesion, and then with the use of a road mat, we can bypass through the stenotic lesion with the use of for the 0.014 guide wire.
So with the use of new implants and techniques, all brain aneurysm can be treated safely. So if neurosurgeon will tell you that this aneurysm is for neurosurgeon, you can say that with all the devices, all the techniques, all the techniques that we can mix, we can treat all aneurysm endovascular. So there are no aneurysm that we cannot treat endovascular. So now I think that there are no aneurysm for neurosurgeons, for neurosurgeon clipping, because with all the devices we can treat and cure all aneurysms.
First technique, stent retriever. There is no evidence that contact aspiration alone can increase the rate of reperfusion over thrombectomy with stent retriever, and therefore the guidelines suggest to use the stent retriever over the aspiration alone as technique. And this is what we performed in this case. We started with an 8 French guiding sheath with a balloon that we inserted up to the C2 segment of the internal carotid artery. Then we moved up with a 0021 micro catheter. We crossed the occlusion, and then we placed a 4 mm in diameter and 20 mm long stent retriever. Usually we try to end with our stent retriever immediately at the beginning of the thrombus in order to get more friction during the thrombectomy. Then we inflate the balloon. That means we block the flow coming from behind, and we perform the thrombectomy. We retrieve the stent retriever, and the colleague aspirates through the guiding sheath in order to avoid some further embolization.